This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined as always by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal BMC Anesthesiology, published in 2026. While our audience is primarily focused on the nervous system, this study hits at the heart of what we do, managing pain through the precise targeting of peripheral nerves. We're discussing a randomized trial comparing two regional anesthetic techniques, the ultrasound-guided external oblique intercostal plane block, or EOIPB, versus the posterior transversus abdominis plane block, known as the TAPB.
This is particularly relevant for those of us involved in spine surgery or peripheral nerve work because the study focuses on providing postoperative analgesia for open nephrectomy. Now, Ilera, for the neurosurgeons listening who might wonder why we're discussing nephrectomy, these procedures result in considerable postoperative discomfort. Traditionally, we've relied on opioids or epidurals, but as we know, those come with a heavy baggage of side effects.
Exactly, Dr. Aris. The paper notes that opioid-based pain control is associated with pruritus, postoperative nausea and vomiting, PONV, and respiratory depression. In at-risk populations, like those with obstructive sleep apnea, we worry about oversedation and apnea. And while epidural anesthesia is a gold standard, it's linked to hypotension, post-dural puncture headaches, and restrictions on anticoagulants. There are even rarer but serious complications like epidural hematomas or neurological injuries.
Which is why regional plane blocks are becoming so central to multimodal approaches. Let's dive into the anatomy. The study compares the TAPB and the newer EOIPB. Can you walk us through the technical differences described in the paper?
Of course. The TAPB is a well-established technique where local anesthetic is deposited between the internal oblique and the transversus abdominis muscles. It's been used effectively in various abdominal surgeries and renal transplantations. However, this study looks at the posterior approach of the TAPB. On the other hand, the EOIPB is a relatively new player, introduced by El-Sharkawi et al. Back in 2021. In this block, the local anesthetic is injected between the external oblique and the intercostal muscles.
And the goal of that EOIPB injection is to target the thoracoabdominal nerves, right?
Exactly. It targets those nerves to provide analgesia to the upper lateral abdominal wall. One significant advantage mentioned in the paper is that the EOIPB can be performed in the supine position, which isn't always the case for other blocks, and it offers broader midline coverage compared to the serratus intercostal plane block.
Let's get into the methodology of this trial. It was a prospective, randomized, double-masked trial conducted at Tanta University hospitals. They looked at 40 adult subjects, ASA 1 or 2, undergoing elective open nephrectomy.
They divided them into two groups. Both groups received a 20 milliliter volume of 0.5% bupivacaine after the induction phase. The primary outcome was the cumulative 24-hour pethidine consumption. They also looked at a variety of secondary outcomes, intraoperative fentanyl requirements, time to first rescue analgesia, and pain scores at 0, 4, 8, 12, 18, and 24 hours.
Let's talk numbers, because the results were quite striking. What did they find regarding the primary outcome of pethidine consumption?
The difference was statistically significant. The EOIPB group used significantly less pethidine than the TAPB group. Specifically, the EOIPB group consumed an average of 61.5 plus or minus 24.77 milligrams, while the TAPB group consumed nearly double that, 114 plus or minus 12.31 milligrams. The p-value there was less than 0.001.
That's a massive reduction in opioid burden. And what about the duration of the effect? When do these patients first ask for help?
The EOIPB group had a much longer time to first rescue analgesia. It took about 7.25 hours for the EOIPB group, compared to 6.1 hours for the TAPB group. Again, a significant p-value of 0.007.
As neurosurgeons, we're always looking at the dermatomal coverage. The study found that the EOIPB group had significantly lower pain scores at the 4, 8, 12, and 18-hour marks post-surgery. Why do the authors think the EOIPB outperformed the posterior TAPB in this specific setting?
The authors suggest that the EOIPB provides superior early postoperative analgesia because it effectively targets the thoracoabdominal nerves that supply the upper lateral abdominal wall. In an open nephrectomy, the incision is often high and lateral. The EOIPB seems to provide better coverage for that specific sensory distribution than the posterior TAPB, which might be more focused on the lower abdominal wall depending on the level of injection.
It's interesting to note that by the 24-hour mark, the pain scores between the two groups became similar. So the superiority of the EOIPB is really concentrated in that first 18-hour window. the most critical time for acute postoperative pain management.
Exactly. And that reflected in the patient satisfaction scores too. The EOIPB group exhibited significantly higher patient satisfaction, with a p-value of 0.045. When patients are in less pain during those first few hours and require fewer systemic opioids, their overall experience improves significantly.
Now, safety is always our priority. Was there any trade-off? Did the EOIPB group have more complications?
No, that's the beauty of it. The study reported that both groups had similar profiles of adverse events. Both techniques demonstrated comparable safety profiles.
This is a crucial takeaway for our residents listening. When we think about personalized pain treatment, as the authors call it, we have to look at the specific nerve pathways involved in the surgical site. For a lateral incision, like an open nephrectomy, the EOIPB offers a more anatomically targeted block of the thoracoabdominal nerves than the standard TAP-B.
It really highlights the evolution of regional anesthesia from broad field blocks to these more specific fascial plane blocks. The fact that the EOIPB is performed between the external oblique and intercostal muscles makes it quite accessible under ultrasound guidance.
So, to summarize the conclusions of the study for our audience, in adults undergoing open nephrectomy, the external oblique intercostal plane block provided superior early postoperative analgesia compared to the posterior transversus abdominis plane block. This was evidenced by lower pain scores for the first 18 hours, reduced overall opioid requirements, a delay in the need for rescue analgesia, and higher patient satisfaction.
It's a compelling case for adopting EOIPB as part of a multimodal analgesia protocol for these types of procedures. It achieves that goal of adequate postoperative pain control, which is key for enhanced recovery and improving the quality of life in the immediate postoperative period.
It also serves as a reminder for us in neurosurgery to keep an eye on these developments in regional anesthesia. Whether it's for spine surgery or peripheral nerve decompression, understanding these fascial planes can help us collaborate more effectively with our anesthesia colleagues to minimize the opioid footprint for our patients.
Definitely. This study, registered under NCT 6452238, provides a very solid foundation for that clinical shift.
Well, that's all the time we have for today's deep dive. I want to thank Dr. Alara for breaking down the technical aspects of this study.
My pleasure, Dr. Aris.
And thank you to our listeners. Remember, staying updated on the latest evidence-based techniques is what moves our field forward. We'll see you next time on the Neurosurgery Hub podcast.